It's depressing after having seen what the endoscope can achieve, the limits of endoscopic sinus surgery, so to speak. We go back to discussing what are failures. And that also failures in routine endoscopic sinus surgery that we do from day to day. But of course, as diligent surgeons, we do see failures, both ours and those of others. And we do need to introspect, to look deeper, to analyze. And we do also understand that the best way to analyze and to improve our results is to analyze failures. So to that aim, my talk is directed. And before I start, I'd like to acknowledge my teachers, Dr. Dharamveer Sethi, Dr. Heinz Stamberger. Dr. Dharamveer Sethi has taught me almost everything that I know on sinuses. Dr. Stamberger, from whom I've learned that to do endoscopic sinus surgery, you have to have the delicacy of a stapes surgeon. So before we analyze failures, let us see what constitutes a success. As we all know, the aims of our standard endoscopic sinus surgery is to give an asymptomatic patient who has well aerated sinus cavities, having good mucociliary function with a minimal derangement of anatomy and physiology. All of us know that, but it's not a new concept. This has been there from 1945, when Van Elia, who is regarded as the father of modern sinus surgery, said that the health of a sinus is maintained only as long as it is lined with a functioning mucous membrane and equipped with adequate drainage facilities. The rhinologist must therefore direct his attention towards the restoration and maintenance of adequate drainage channels, and this to be done with the least possible damage to the functional nasal and sinus structure. This was said more than 50, 70 years ago, so there's nothing new in this. However, we still come across sinus cripples. We come across situations where too little has been done. We come across situations where too much has been done. Now, when does one decide when is too little? When is it too much? When we start at the selection. Now, the selection reasons for this failure of endoscopic sinus surgery is, of course, inappropriate case selection. You have gross chronic smokers with deranged mucociliary function. They will have that smoker's cough, they'll have that chronic rhinorrhea, whatever you're going to do. People who work in environmental exposure have rhinorrhea due to that. They're going to have that whatever you're going to do. But more than that is the problem of inappropriate case selection. Now, this is one case in which a septoplasty and minimal fess was done by somebody, and that person had wide cuts. This was done in a smaller city where 6 or 7 millimeter cuts were used. They failed to recognize this patient who was dripping pus from his nose, pre as well as post-op. They failed to recognize that the cause of sinusitis was this. So there's no point, at the end of it all, they ended up giving him a septal perforation and removing the Ansonet process and long extensive notes, but they forgot to look for other pathologies. So this would be inappropriate case for just an endoscopic sinus surgery without dealing with this pathology. What about mismatch in expectations? God help the guy who wants to operate and cut out all this person's sinusitis when his main complaint is that I want to stop my running nose and sneezing, doc. And then you have a CT scan like this, and then you punch out all of this, and all of that, and the patient comes back with worse symptoms than before because he has symptoms that may not be relieved by clipping off all of his sinuses. So you try to please this patient, you're going to be met with disaster. And at the end of it all, this is functional surgery. This is for the patient's quality of life. This is not life-saving surgery. After that, we look at poor pre-operative preparation. Sometimes a lot of us are in a hurry to get this patient onto the table before our neighbor gets him onto the table, So before that, we bring the patient onto the table. We must understand that in order to treat this patient, we must first remove the infection. We must give him an appropriate antibiotic. Look for the culture, look for the sensitivity. While you're waiting for culture sensitivity, give him a co-amoxiclav, give him a cefuroxime, give him something, but remove the infection first. Lessen the allergic response. A proper course of steroids, proper course of immunotherapy. At our clinic, we believe in allergy testing and immunotherapy. We believe that the best way to eliminate the inciting allergen is not only surgery, but also antifungals as an adjunct to our surgery. And of course, our supportive therapy. In our clinic, we follow a preoperative preparation of giving corticosteroids, provided there are no contraindications, of course. Culture-directed antibiotics, co-amoxiclav to start with, then we go on to culture-directed antibiotics for 14 days pre-op. And what we isolate is commonly strep pneumonia, H. influenzae, Moraxella catarrhalis, and also staph. We have to look for staph. Sometimes there is a paucity of staph, but the reason that we look for staph is the problem that we deal with staph superantigens, which I will talk to you a little bit later. Decongestants, of course, but one does not give pseudoephedrine to a guy who's 70 because of the prostate problems. Local steroid sprays and antifungals up to 4 weeks pre-operatively in cases of allergic fungal sinusitis. Thus prepared, the patient is more or less ready for your sinus operation. But when you are doing his preoperative evaluation, one must also pay attention to undiagnosed allergies, undiagnosed posterior inferior terminal hypertrophy causing obstruction, undiagnosed adenoids. We have had 8 cases till now of tuberculous adenoiditis in a patient with sinusitis as well as blocked nose. So think in terms of all of these things before. So these are the
places where one has to stop and think while selecting the patients. When you are investigating the patient, of course, CT scan is the gold standard, we all know that. However, most of us instruct the patient to have a CT scan immediately upon presentation, which is inappropriate as 90% of patients with URDI will have CT changes, that includes you and I. And therefore, the best time is not to, the aim of life to do a CT scan is not to show the patient the opacification in the sinuses, but to create a knowledge of 3 dimensions of the nasal sinus anatomy. So therefore, what we do is we give minimum 4 to 6 weeks of conservative treatment before we subject
a patient to CT scanning, unless of course diagnostic endoscopy suspects a sinister pathology. Take the patients to treat the patient before a CT scan is ordered. However, the problems with CT scans are that they don't show minimal disease, they frequently show asymptomatic changes. And there is very poor correlation sometimes between CT scans and symptoms. And therefore, CTs can be used okay as a snapshot in time. It is more for the anatomy rather than the pathology. Now this, for example, if you will note very carefully, this is a Haller cell. I had the good fortune or bad fortune of following this patient from 97 when I offered him surgery for this Haller cell. And he refused it at that time and came back in 2003 with full-blown polyposis. Therefore, the most important part for the CT scan is that one should not neglect the potential for predisposing anatomic variants to produce disease. This would be an absolute indication sometimes to go in for surgery, depending on the symptoms. Of course, when we come to the surgery, a surgery is the sum total of our habits, good or bad, our passions, which have been created over time, our preference, depending on what we do best, and sometimes prejudices which have been stuck in our heads. And when the poor surgeon is confronted with all of these, and he has to decide the patient, what to do for the patient, the surgeon will then start thinking, what shall he do? Shall he do a minimally invasive technique? Shall he do a total sphenoethmoidectomy? Shall he do a classic FES as proposed by the Messer-Klinger techniques? Should he do a skull-based dissection? The poor surgeon also is confused. So sometimes what he has to do, he has to go back. He is encouraged to look at his literature, encouraged to listen to his peers talking about all of this, and create his own paradigm following which the proper surgery can be possibly performed. But every surgeon should keep in mind Fish's dictum that it should be the result of a logical plan. All noses are not the same. Therefore, every patient should have customized surgery for his nose. And when we operate on his nose, we don't go crunch into the bulla ethmodalis, we think stapedectomy. We operate on the nose with the delicacy of a stapes surgeon, and then we are most likely to end up with a reasonably good result at the end of it all. Of course, when you go in for surgery, you are going to go into the aims of surgery. What are the aims of what you are planning to do? First, you want to eradicate the disease process. You want to restore normal function. You want to create maximal mucosal preservation. You want to prevent recurrence, and of course, you want symptomatic relief of obstruction, rhinorrhea, headaches, etc., etc. And sometimes, when you really analyze this, you find that some aims are contradicting the other aims. For example, you can't completely sometimes eradicate the complete disease process with maximal mucosal preservation. So this is a tarazu, this is a sort of balance where we have to think which way we shall tilt our operation. And the first dilemma is that what is the role finally of surgery in rhinosinusitis? Is it a first aim? No. It's always after maximal medical therapy. But of course, one can move towards surgery, in which cases of associate turbinate dysfunction is there. In cases of anatomic variants which are found with your CT scan and the patient is quite symptomatic, such as a compromised osteomeatal unit, a very narrow nose, gross septal deviation. Sometimes, even myself, I am tempted to do video nerve cauteries when the patient has gross allergic symptoms in addition to sinusitis, in spite of doing his immunotherapy, in spite of doing his allergy testing. Then I am tempted sometimes to do a video nerve cautery, but this is a controversial topic. Maybe we can talk about it a little bit later. The next dilemma is that shall I do a transitional space surgery, that is the MIST, the minimally invasive, or a classical FES. The proponents for transitional space surgery say that it speeds healing. It improves sinus function because they say that airflow reduces mucociliary clearance, as the Japanese say. And of course, it's certainly appropriate in children. However, in our setting, in our country, it is probably not adequate for the typical surgical indication, as we'll go and see. The second stage is much more difficult. It's not generally a second stage, it's generally revision surgery. And bony partitions harbor disease, and therefore recurrence is much more likely. Now, this is something that as a student we used to hate definitions, but as practicing surgeons, let us go back to the definition. Chronic rhinosinusitis is a multifactorial group of disorders involving the mucous membranes, the fluids of the sinuses, and the underlying bone. Now, this is a very important sentence because it tells us that sometimes minimally invasive surgery will not allow us to take out the osteitis. Now, as you know, every year there is a rhinology task force and they have to do something, so they keep changing the definition. So that was the definition in 2003. The next augmentation to the definition came in 2004 of chronic rhinosinusitis with nasal polyposis and SANS, that is without nasal polyposis, but that's beside the point. Now, when you consider rhinosinusitis, let us consider the role of bacteria. They are definitely implicated in 70 to 90% of acute cases, but in chronic rhinosinusitis, the role of bacteria are questionable. Today, Kouwenberg in Belgium says that chronic rhinosinusitis represents a repeatedly damaged mucosal lining that has lost its normal state of sterility. And there's a minimal role of bacteria except in acute exacerbations. And therefore, one has to look deeper into other causes that are precipitated not just by the actual bacteria, but by a reaction to the bacteria, such as the osteitis. Now, the problem with osteitis is that this is a histopathological diagnosis made in the lab, not the OR. The question is, what if the osteitis involves the lamina or the fovea? Are you going to remove that? Of course not. Is it reversible? If so, how much medicine or surgery is required for its reversal? We don't have answers to these questions. But till we have answers, one should be conservative. And for the theoretically minded, of course, the latest is a single photon emissions CT. It's the SPECT that will identify a focus of osteitis. This is just theoretical. Now, today what they talk about is the role of biofilms. Why am I telling you all of this? Because when you talk about biofilm, a biofilm is a glycocalyx formed on a damaged biological surface, the importance of which is that it explains the frequent negative cultures, and the only possible way out to destroy this biofilm is mechanical debridement. And therefore, the minimally invasive procedure is generally not going to work in CRS, at least in our setup. The problem is then also the role of superantigens. So what are superantigens? Exotoxins that directly go into the complement pathway, and therefore excite 30% of T cells, as opposed to the normal excitation of 0.01% of T cells. And this is also to be included as far as polyposis is concerned. So you will do a nasal smear in polyposis, you may or may not find fungi, you may or may not find staph, but you often need to, that the staph enterotoxin A and B will cause superantigen specific degranulation and nasal polyposis, and therefore aggressive debridement is required because staph is known to create extensive osteitis with skip lesions. Therefore, a couple of cells may be normal and then you'll have osteitis of the other cells. And therefore, this can be a possibility for more aggressive approaches. But of course, we all know that minimal persistent inflammation is an underlying cause of chronicity. So at the end of it all, what do we have? Let us try and divide in our minds what is the best candidate for minimally invasive surgery. The best candidate for minimally invasive surgery is a candidate in whom you have endoscopic confirmation of disease, radiographic neo-osteogenesis, major anatomic anomalies corresponding to the signs and symptoms, and patients who complain of severe pressure symptoms in the ethmoids during aircraft travel. Such cases, a minimal FES is bound to produce very good results. Who are the good candidates for maximally invasive surgery? Allergic fungal sinusitis, we can't pluck away an ostium, an uncinate and say that our job is done. Pan-sinus pathology, we can't say, okay, we will not touch and allow the frontal recess to aerate itself. You need to do extensive debridement. You need to remove all the bony septa, a radical exentration, a complete mastoidectomy of the ethmoid, so to speak. Vigorous removal of allergic mucin. It's no use just applying a suction. You have to really debride the mucin off. It is the allergic mucin that produces the polyps. And unless you really aggressively remove it, it's going to happen again and again and again. And you can keep plucking away all the little bits and pieces in the nose and have totally blank nose and still have gross polyposis, because this particular aspect was not done. Thorough washes with antibiotics are recommended intraoperatively as well as postoperatively. Of course, some patients who have guarded prognosis as far as the work is concerned, you tell the patient that, look, we will try and help you. And these are guys with reactive airway disease. These are guys with untreated allergies, people who complain of severe non-specific headaches and heaviness of the face. Mid-facial pain sometimes tempts us to go in for endoscopic sinus surgery, especially with compromised osteomeatal units. But please be assured that unless you do a proper xylocaine test with the patient having a headache and the patient not knowing what you're putting in his nose, please don't try and operate on such cases. Sometimes you will end up with a lot of disasters. Poor candidates for endoscopic surgery are, of course, patients with migraines and atypical facial pains, chronic smokers, patients with a lot of symptoms and all you see is an isolated maxillary cyst or so, and patients with chronic environmental or occupational exposure. Now, going on to the surgery. The first and most important cause of the failure of endoscopic sinus surgery that we have seen in our clinic is a retained uncinate process and poor management of the infundibulum. Now that again presents us with a dilemma. Some of us tell us we should do a complete uncinectomy. Some of us tell us let us do only a partial uncinectomy, a lower third uncinectomy. Some says leave the ostium alone. Some people say do a mega osteoplasty. People say do a turbinectomy, people say don't do a turbinectomy. So what shall we do? Let me try and clarify a little bit. At the risk of sounding very backward, let me again go over the variations of the uncinate process, inserting on the lamina papyracea, inserting on the skull base, and sometimes inserting on the middle turbinate itself, in which your sickle knife will lead you straight into the orbit, and therefore retrograde dissection of the uncinate is the most preferred way of performing an uncinectomy. This is just a couple of examples of an uncinate process. But in our clinic, we perform uncinectomy in a retrograde manner to prevent orbital complications, making sure the superior limit of your uncinectomy can be variable. If there is no frontal disease and no agar nasal disease, one can do a limited uncinectomy, but the horizontal process of the uncinate has to be removed in toto. Now, as far as the ostium itself is concerned, the ostium, the first ostium that you see is always the accessory ostium. In an unoperated case, having an uncinate process, a diagnostic endoscopy revealing a maxillary sinus will never reveal the natural ostium in your first or second passes. The natural ostium is always hidden behind the lower third of the uncinate process in this little triangle, and therefore, unless the uncinectomy is properly done, one does not see the natural ostium. In the presence of an accessory ostium, we recommend that the two of them should be joined to prevent the recirculatory phenomenon. And in absence of that, how does one decide how big an osteoplasty should be? There was some work conducted jointly with Scott Graham of the University of Iowa. in which xenon fluoride clearance in a sheep, this is the sinuses of a sheep that you see, a very, very elegant looking picture. This is a sheep CT scan. The xenon fluoride clearance study showed that there is no difference in the ventilation between small and large ostia, that is ostia from 3 millimeters upwards. However, significant ventilation change from baseline is afforded by any enterostomy as far as a chronically stenosed ostium is concerned. So when you see an ostium that is less than 2 millimeters across, it should be opened moderately, not necessarily a mega enterostomy. A lot of people from the south say just do an uncinectomy and forget about this. That is not going to work in a small stenosed ostium. One has to enlarge it to a moderate extent, except in cases of gross disease and mucoclearance disorders in which you want to do a mega enterostomy. Now, as far as the enterostomy is concerned, again at the risk of sounding a little bit backward, let me emphasize that it is always done at the expense of the posterior fontanelle, never at the expense of the anterior fontanelle. This area of the mucosa is regarded as sacred to prevent circumferential stenosis in the postoperative period. There are a lot of times in the earlier days when people used to recommend a retrograde enlargement using a backbiter. The backbiter is not used to enlarge the anterior fontanelle. It is to remove the inferior attachment of the uncinate. So the edge of the backbiter, now the tip of the backbiter is used. And one does not allow any contact with this area of the mucosa because that area will prevent circumferential stenosis. Posterior fontanelle, you can see what a huge enterostomy can be created. So there is no problem in the posterior fontanelle. The problem of mucus recirculation creating a postnasal drip has been well studied, and therefore we advocate that any patient who has an accessory ostium should have it joined to the natural ostium. Now this is a case that came to us in which the accessory ostium was large on both the sides, but the natural ostium and the uncinate process was still intact. So what the surgeon had tried to do was during his diagnostic endoscopy, he saw the ostium and enlarged it posteriorly, not knowing that the natural ostium is far anterior and sometimes very, very small. And therefore, this patient continued to be symptomatic with persistent CT scan changes. So the moral of this story is to remove the uncinate properly and to join the natural ostium to the posterior accessory ostia. And don't rush for the accessory ostium. When you see the natural ostium, join the two of them. Now what about dealing with the middle turbinate? Shall we cut it away? Shall we leave it in place? What shall we do? In cases where there is a gross obstruction of the nasal valve angle, a proper septoplasty of course should be performed. But when you have a paradoxic situation such as this, rather than lateralizing the medial turbinate or medializing the medial turbinate and thus fracturing it at its base, what we today recommend is a partial turbinoplasty involving the anterior part of the middle turbinate. That in my clinic in the past we used to achieve with laser, now with through cuts and debriders, just to see how it goes. Just the anterior part is removed to create access into the infundibulum out here. And if you have a delicate attachment of the skull base out here, a laser works extremely well in opening up the area of the infundibulum. And the reason for this is that we don't want to render the turbinate floppy. Bulgarization is essentially medializing the turbinate and attaching it to the septum, but that may sometimes, according to Dr. Nick Jones and Dr. Daniel Simon of Switzerland, they recommend that it blocks off the olfactory fossa and creates problems with olfaction in the future. And therefore, bulgarization should only be done in the rarest cases when you have a floppy turbinate, and try to avoid creating a floppy turbinate in almost all cases. Another problem that we see is persistent frontal recess disease. That is due to inadequate identification of the frontal cells, inadequate surgery. Now this is the preoperative, this is the postoperative. Why does that happen? Firstly, the missed cells due to poor imaging and no sagittal reconstructions. Therefore, we recommend that whenever a frontal disease procedure is potentially there in your patient, one should do a sagittal reconstruction. As far as the lateralized middle turbinate is concerned, that happens due to excessive manipulation, as you saw in the previous one, how to prevent the excessive manipulation of the middle turbinate. Excessive removal of the mucosa of the lateral wall of the middle turbinate also causes the lateralized middle turbinate. And circumferential stenosis of the frontal recess occurs due to excessive denudement of the mucosa, as well as persistent osteitis, and therefore excessive denudement of the mucosa is not recommended in the frontal recess. Just try and preserve as much as possible the mucosa in the frontal recess and allow the patient to heal naturally. As far as inadequate surgery is concerned, that is only due to a failure to understand the disease. Say, for example, this patient. This patient has a large concha bullosa, has extensive sinonasal disease. Post-operatively, he no longer has a concha bullosa and continues to have extensive sinonasal disease. Why is that so? A failure to understand what the patient requires. Recognition of the disease. This disease is not the same as this disease. This is an anthracoanal polyp. This is gross allergic fungal sinusitis. We deal with these two diseases in different ways. One does not perform the same procedure for this one as well as that one. Finally, one comes to maximal surgery with abysmal technique. Now, before one goes on to maximal surgery, one has to really look into the anatomy, the physiology, the radiology, and then decide on the best way to go about it. Now, in this case, you can see the patient had come to me post 2 times functional endoscopic sinus surgery had been performed. Can you tell me exactly what this patient has in each of these, and you will realize what are the problems that the surgeon had in doing these procedures. He had breached the lamina papyracea. However, he has not removed the uncinate process. The agar nasa are not well exenterated. The bular sheath is too large. The natural ostium is not connected to the accessory ostium. See them again, and then you will immediately come to know why this patient continues to remain symptomatic. He continues to remain miserable. He is still a very unhappy patient. Post-operative, just because we have finished our endoscopic sinus surgery properly, we have done a perfect job, we have done the right indications, done the right job, that does not mean that we forget about the patient. Appropriate long-term medical treatment is very much emphasized, and if one listens to all the senior surgeons talking, such as David Kennedy, such as Draff, everybody says that you have to really look after the patient post-operatively in order to achieve a good result. Proper endoscopic lavage, proper endoscopic debridement, proper steroid use, both systemic and topical, proper use of antibiotics, because you're going to treat this patient as an osteomyelitis. If you see the pus, one cultures it. A lot of saline, and sometimes in gross polyposis we use antifungals up to 6 weeks or even up to 2 months post-operatively. Why? All of this is to prevent recurrence. And in cases there are, if you see bare bones, you can continue antibiotics up to 1 month. If you see granulations in your post-operative period, we use a mixture of hyalase and triamcinolone gel foam, put it in the nose for a couple of days, suck out the gel foam, because if you leave it there, it's going to cause adhesions, because gel foam is very fibrinogenic. But you leave it there overnight, remove it the next or the third day, and then it will not cause a problem. And the triamcinolone and hyalase will have had a time to act. If in the post-operative period you see a lot of cobblestoning, one uses Neosporin and Metrogel gel along with the steroid instillations to prevent formation of polyposis. Allergic mucin, the moment you find it reforming, one should aggressively remove it. Moral of the story is that one has to spend a lot of time with the patient post-operatively in order to prevent a recurrence. Poor endoscopic follow-up is really a cause of post-operative failures, because endoscopic controlled cleaning and lavage should be continued ideally till you see endoscopically the mucosa returning to normal. We must know that even slight trauma to the nose causes derangement of the mucociliary clearance. One has to remember, and this is a fact made very emphasized very strongly in Europe by Hans Baerbohm, that the surgeon has to do the mechanical clearance till the mucosa normalizes. You are doing the job of the mucociliary bodies. You are doing the job of the gel layer and the sol layer of the mucus till the mucosa normalizes. So debridement is in your hands. Cleaning is in your hands. Lavage is in your hands. You can't tell the patient, go home and wash your nose and come back after 6 months. That just doesn't happen. Then you will be ended up with the failures. So all of this, I hope, has gone to some extent in clarifying or maybe sometimes confusing all of us as regarding what should be done for the sinus surgery in order to maximize our results. And in conclusion, I would like to give a thank you to people whom I've worked with excessively. And all of them have only one message to give, that nothing can substitute a perfect knowledge of anatomy and the radiology to give a proper, good post-operative result. Thank you very much for your attention.